Hey everyone, I'm Austin, and my project was utilizing the deep learning techniques to detect early stage periodontal diseases. Um, so my idea for this project was to utilize state-of-the-art performing image classification tech and apply them to the dental field. The dental field arguably is less developed than other fields of medicine due to lack of emphasis on preventative care and early detection, which means that there's a greater focus on treatment options. The CDC did a study, and only 64% of Americans in the past year have actually seen a dentist. And additionally, the NIH found that half adults over the age of 30 have periodontal disease. And this further highlights the need for early detection and intervention. Early detection is crucial to help us prevent the progression and save teeth from being lost. Additionally, periodontal has been linked to other systemic health conditions, such as heart disease and diabetes. So this detection and treatment could potentially improve overall health outcomes, not just in the dental region. By analyzing these features, such as gingival bleeding and pocket depth, machine learning models can potentially detect periodontal disease at an earlier stage than traditional methods. So research has shown that the gum disease is linked to other systemic health conditions, like I mentioned before, such as heart disease and diabetes, could lead to strokes. And it's essential to practice good oral hygiene, brushing, flossing, all those regularly recommended things that dentists do. So there's two main types of gum disease. There's gingivitis and periodontitis, which is not to be mistaken. Gingivitis is the earlier stage of the disease, characterized by the red and swollen bleeding gums. If left untreated, that will typically progress into periodontitis, which cause the gums to recede and the bone that supports the teeth to actually deteriorate, causing tooth loss. So it could lead to actually some pretty bad medical health conditions, among other things like bad breath, tooth sensitivity, etc. But the more advanced stage of this disease is periodontal. And it is a chronic bacterial infection that infects the tissues surrounding the teeth. Essentially, it's a disease that attacks the gums and periodontal ligament and alveolar bone. In a given X-ray, we could see in the examples on the right of bone loss and the periographical radiograph. And there's a proximal crater in green, bone loss in red, and a bone defect in the blue. Very, very subtle. In 2017, the earliest paper I could find was 2017 regarding this topic. But they did not make such efforts as the 2019 paper, Croix et al., who the title of the paper, Deep Learning for Radiographic Detection of Periodontal Bone Loss. They applied a deep CNN to panoramic radiographs to potentially reduce the workload. Additionally, there were other iterative works off this specific paper that I thought would be great resources for this project. And the most recent works coming from this 2019 paper from Coys is the 2022 paper from Jiang et al., titled a two-stage deep learning architecture for the radiograph stage, of periodontal bone loss, where they applied a two-stage deep learning architecture based on UNet and YOLO v4, and was proposed to localize the tooth and extrapolate the details from there, rather than a larger, more quad-focused, like other papers have, quad-focused imaging of the mouth rather than individual teeth. But moving on. The data set I used was from a private posting on Kaggle by Mohammed Sajjad. Kaggle is just a platform for data scientists and other engineers to post data sets to be used for things and projects like this. So the data set consisted of 534 X-rays from the Armed Forces Institute of Dentistry in Pakistan. These X-rays were labeled by radiologists and dentists to indicate the presence of very specific tooth lesions, four of the classes are indicated here: a primary endo, a secondary perio, as you can see, a missing tooth; primary periodontical, meaning very, very jagged, destroyed tooth; perio with more gum bacteria; and then primary perio, which very deep, dark black bacterial infections. So for this experiment, I wanted to test a variety of test cases with a mixture of training sets and model types. So I started with this initial hypothesis, training a model using annotated periodontal x-rays and leveraging deep learning techniques may enable the detection of early forms periodontal rather than established, and assisting in dental professionals in the early detection and prevention. For these experiments, I wanted to test a variety of open source models, both pre-trained and not pre-trained. I used the ResNet 18 and 50 models. I did not affect the architecture of these models. I used this as the goal to attain the highest level of success with the current open source architectures. The ResNet 18 is commonly used for image classification, not very large in comparison to the ResNet 15, where it's often more complex image recognition tasks, such as like object detection and segmentation, etc. So beginning with one of the first set of experiments. The model was trained for 10 epochs, divided batches of 5 with a small learning rate of 0.01, stochastic gradient descent, cross entropy loss. And as you can see in the top right, I use the primary perio and primary perio with secondary endo subclasses to train upon. And you could see there was an obvious issue going on. There was an overfitting problem that I found, and this led me to investigate the data set and classes for the model. And after looking further, it was an obvious class imbalance. This is a reasonable issue to run into based on mainly three considerations when considering 3 things. Difficulty of obtaining x-rays, proper labeling, and the volume of available data. I found it pretty difficult to obtain patient x-rays in this type with proper labeling and formatting for ease of use for like training a model like this. So I wasn't too worried about that. So to overcome this problem, I began tweaking the hyperparameters. And so that made me go to the learning rate first, which I reduced drastically to see if I could slowly creep up to the adequate training numbers. Additionally, I extended the epochs to 100 and remained the batch size to be 10. So we still see there is a pretty bad overfitting problem. So that wasn't the fix. So on the third experiment, I was looking to see what I could do to help kind of eliminate this issue even further. I applied a pretty drastic learning rate, weight decay on cross entropy, and also the augmentation of data. It's a very difficult set of transformations. As you can see, I have a snippet from the code base that I have, and it's pretty drastic. I was looking to break the model and break the speed of learning to get some better results. Even with the extremely rigorous data augmentation, I still saw a similar overfitting issue at a cap of around 75% accuracy. I was unsure, training accuracy also, to be clear. I was unsure of where I could make the next substantial change to fix the continuing issue. And so if you know, the best performing model in this experiment, number 4, was the pre-trained ResNet 50. The ResNet 18, like I mentioned earlier, is a lot smaller than 50, and it may be the case that fine-tuning of training is better performing over the larger model. I continually applied in this experiment the same difficult augmentation and regularization and optimization as prior experiments, as the prior last experiment, to help introduce, and also to help introduce some generalization. I'm sorry, let me step back. I continually applied the augmentation, and also, so to help introduce some more generalization of the model. Because there is a key issue of understanding the dental x-rays, that because I wanted to search for some generalization in the model to build it, I wanted to do so because of the difficulty and consistency of x-rays on teeth. And as a side note to that, because this data set and because obtaining dental data sets is a little more difficult, the labeling was not specific to quad sections in the mouth, so it's a little more complex to, so it's less complex and requires more generalization in sections of the mouth, because the tooth cannot, or the model cannot determine what a canine is versus a molar, and between baby teeth and adult teeth growing in, so it may seem to classify certain things incorrectly. So this model had a little more, or this training set had a little more better performance. As you could see, there was a more gradual growth to accuracy, and with a few exceptions of larger, more overfitting type grafting. But the failures of those experiments kind of took me in a different direction. It made me rethink what I needed to do differently. So after some consideration, I decided to change my training approach to the alternative disease classes in the data set. So if the model has the ability to generalize, so the model does have the ability to generalize from the non-important diseases like endodontic. In this case, endodontic is important, but in this case, because I'm looking for periodontal and primary endodontic diseases with small developing periodontal lesions. So I made this change to the extreme overfitting and poor test results. So in the experiment number 5, I decided to use the primary endodontic with secondary perio, so small traces of periodontal disease, and a primary endodontic lesion. And the results are a little more sustainable for my training. The testing resulted in higher accuracy than any of my prior experiments, which I thought was odd, being that I only gave it very few doses of what periodontal disease would look like. But I thought it was a step in the right direction. And then lastly, in my 6th experiment, I wanted to run, was a step backwards from the full generalization idea that I had, like in experiment 5, was with not introducing much of any periodontal disease into the training, but now introducing conflicting primary endodontic with primary periodontic to learn the nuances of the small early stage and more large and more prominent perio lesions between the data sets. To my surprise, this was the best performing training pair of many I experimented with. The testing results for this pair and set of models was in fact the best. If you look at the top right, the non-pre-trained ResNet 50 gave a performance of 32% test accuracy, and the non-pre-trained ResNet 18 gave an average accuracy of 15%. Very poor performance overall, honestly, but marginally over the lifetime of my experiments, it showed great improvement. And the preliminary results, as I mentioned before, was that ResNet 50 model performed the best, not pre-trained, and the data sets that performed the best with that model was the primary endodontic and periodontal, with secondary perio and primary perio lesions. So that's my preliminary results. I think the next best step going forward would be to obviously continue to find combinations of the existing data set that would perform the best with these models, as well as if you were to able to classify them properly and probably build a model that's more reliable, you could further extend these experiments onto more image segmentation and build out the data set from there, and probably find a classifier and segmentation to help not only identify and classify, but also identify which regions of the mouth are being affected more prominently than others. And so that will be all.